We're going to go ahead, before I actually introduce our speaker, I do want to mention that you may want to have a pencil and paper to take some good notes, and also that we're going to have a promotion at the end of the webinar that we're going to offer, so we want you to stay around for that. And then we're going to have a time for a Q&A, so we want you to really get your questions prepared, and we'll have an answer, hopefully a good answer for you at the end of the process. So anything, as the saying goes, there's not a bad question, especially when it comes to MDS. There are a lot of questions out there that a lot of people are asking and needing answers to. And so take advantage of this time while we do have our expert with us, and hopefully you'll have the answers that you've been looking for a while. I do want to introduce Rosemary Gonzalez. Rosemary Gonzalez is our Director of Training, and she comes with 43 years of nursing and 8 to 9 years as an MDS Coordinator. Rosemary is currently working on her BSN, and she's becoming very popular in the industry because she has developed a way to really come out with some great outcomes with clinical and reimbursement from Medicare and Medicaid. So she is fastly becoming the expert, and we're glad that we were able to snag her and bring her on to our organization, and we're very, very excited, to say the least. So at this time, I'm going to go ahead and introduce Rosemary. Rosemary, thank you for being with us today and making this presentation. And so we're going to go ahead and let you take it over. And also, guys, out there is, again, if you have a question or a comment, you can go ahead and start asking those. We may reserve that part of it for the Q&A part of the agenda, but we may even answer some during. So at this time, I'm going to introduce Rosemary Gonzalez.
Hello, good afternoon, and I'm really excited to be with all of you who have joined us. I guess the first question is, what is an MDS? And that's an acronym, of course, and it stands for Minimum Data Set in Reimbursement. The minimum data set function has been around for several years. Now, it has had a different name as the time has gone by. When I first started doing MDSs, we were using at that time what are called tiles. And then in 2010, we received a notice from CMS that we were going to have a different form and a different process in place for MDS formulation. And part of the reason for that was that with the old system that we had, it was a system that had been used for many, many years, because the process of coding and certification has always been a process of long-term care or nursing homes, etc. So the MDS 2.0 was born in 2010, and it came following the tile process, and then in 2012, we went over to MDS 3.0. And 3.0 was put in place because the Centers for Medicaid and Medicare realized that in the process of interviewing and collecting data, that the patient or resident really didn't have a lot of say-so in the process. So the process was revised where a lot of participation from the residents themselves come into play for the MDS form. So now we're dealing with MDS 3.0. Minimum data set is a process and a form that is used particularly, especially in my case, in long-term care, and that goes for nursing homes and rehabilitation combined. So the process that is for us to get reimbursed, for the facility to get reimbursed, is we have to file an MDS to CMS on admission and thereafter on a quarterly basis. So every 92 days, a form has to be developed, tracking all the information that they need and transmitted to CMS. and depending on what is coded on that form, really allows for how much reimbursement the facility gets for the care of that resident. So what I have learned in the process of doing MDSs is that the skill set for MDS has become more complex, let's say. It's become a form that requires special coding. It requires collecting data like nursing, like clinical outcomes, all those things that they need to assess to give us reimbursement. So they want to know about cognition. They want to know the ability to make decisions, to answer appropriately. Are they suffering from depression, those kind of things? Another section would be related to their ADLs, which is an acronym for activities of daily living. How well are they able to turn in their bed? How well are they able to transfer from the bed to the chair? Those kind of things. And the higher the coding, the higher the reimbursement. So if a patient is able to turn in bed by themselves, we would not get as much reimbursement as if we had a patient that needed assistance of one or two people. So that data becomes important to CMS to look at reimbursement. So that's the process of MDS, and I personally think that the time has come for it to be a more professional, formulated skill set, a profession within the long-term care function. As time has gone by, I have really had to broaden my perspective about what MDS really is. So what I found to date is that the resident or the patient that's in the nursing home requires a lot of care, requires a lot of attention, and requires a lot of systems in place to make sure the benefits that they have are delivered to them, and that we MDS coordinators are responsible, in my view, to make sure that those benefits they have are translated into quality care. So that's part of our responsibility in terms of delivering the care plan. So speaking of care plans, care plan is another component of MDS, of the MDS process. When we do an MDS, let's say an admission MDS, depending on whether they're Medicaid or Medicare, we develop a plan of care for that resident or patient. So we're responsible for making sure that the plan of care accurately reflects what that patient needs, what their diagnosis codes are, what treatments they have, that they receive rehabilitation, i.e., let's say if they had a stroke, they're a good candidate for rehab in the facility. So that's what I'm observing of late, is that we really need to have a more formulated training program to really address all of these issues that I am seeing that need to have a very high skill set, a very good clinical skill set as well, because the systems that we derive the coding from comes from clinical documentation, clinical, plans to treat different diagnoses. So we don't have a formulated plan to do that. So my goal is that this is something that I want to project into the future. This is really a profession within the component of long-term care and within nursing. So again, the process has been in place for many, many years, but because of cutbacks in Medicare and Medicaid, we are challenged as clinicians to deliver the care, deliver the benefits to the patient, and make sure that they're getting that for us to be able to capture that and get reimbursement. Now, it becomes a difficult situation when what you code on the form and what is actually done for the patient can be backed up by documentation. So one of the really components that I think is really in need of a lot of improvement is documentation. And I know as nurses we're instructed, we're taught if it's not written, it's not done, and that still stands today. If it's not written, if you didn't give this patient a pain medication when they complain of pain, I can't capture it because you have not documented that it was given. So everything that goes into the MDS has to have documentation to support it. So what happens with correct documentation is that we do not, let me back up a little bit. We get surveyed every year by the state. They come in and do a survey, an annual survey, and they look at all the processes that we have. They look at pain, they look at incontinence, they look at wounds, they look at all those things there, and if we are lax in documentation and lax in delivering the services they need, we get money taken back by the state for not being able to support that documentation, etc. So really what I'm trying to say overall is that it has become a big effort for MDS coordinators to really get everybody on board, get the nurses trained, have them understand what ADLs are, what all the other processes that are in place are. So we have a team of, it's called an interdisciplinary team that meets every day. We meet every day and look at the patient. What are we doing for them? Are there any changes? Do they have a fall? Do they have any wound? All those things. The interdisciplinary team addresses every single day. We look at the changes, we look at all those things that can be captured on the MDS, and if something is not written down, there's absolutely no way that we can code that function or that pain medicine or whatever. So it becomes really, really hard. I'll tell you about a daily function of an MDS coordinator. The first thing I do in the morning when I get to work, and I get there pretty early, is I make rounds. What I'm looking for are any falls, any admissions, any discharges, any wounds, any other behavior issues, and I make note of those things early in my day to know exactly what's going on. After that, every morning we have a morning meeting, and we discuss the care that has been given to the patients, any pain meds that they have received, any new orders, did they get an order for a new medication, did they get an order for rehab, a referral for PTOT or ST. We make a note of all those things, and if we need to, we make referrals out to whoever needs to be on board. For instance, if a patient has a fall, then we give that referral to rehab for them to do a screen and for them to make sure that their fall, any pains, anything of that nature are addressed. So that goes directly to them, and they go ahead and do a screen. We have to provide documentation for them to be able to, quote unquote, pick that patient up. So as nurses that are on the floor, that are charge nurses, that are there every day, we have to make sure that is documented on the clinical note, okay? So that's sort of the daily function, and then we have care plans. This morning we had care plans. Wednesday mornings are care plans for all of the residents that have a quarterly due on this date. Remember I said there's an admission, there's quarterlies, 3 quarterlies, and then there's another admission. So there's a schedule for those assessments to be done. So based on the assessments that were due last week, we do care plans this week to address all the changes in that. So that becomes a real important function of an MDS coordinator as well. We also work very closely with the business office manager. As you maybe have already captured, what we do is revenue producing as well as clinical intervention. So it's not just making money for the facility, but it's also providing the clinical intervention that our residents need. So it's a twofold thing, and so we're asked to, and we are doing that on a daily basis. So we have to work very closely with the AONs, with the DON, with the charge nurses, with the CNAs, to make sure they have all the education they need and the benefit they need to really do a good job. So the term coordination is very real. We are charged to coordinate all these functions and coordinate that documentation to come in to support what we're actually doing for the facility. So another function that we have is with the business office is level of care. So let's say we have 100 patients in the facility, and at any given quarterly, every month that a patient's bill has to be sent to CMS. So we make sure that a level of care is attached to every patient in that facility and that they don't fall through the cracks. So we have a level of care meeting. We go over each patient. We go over the term of their, the period that they have been already paid for. And then we go make sure that they have a level of care. Do they have what's called a RUG, or an equation that has a dollar assigned to it to bill for that month? So everything has to be in place for that. So I guess what I'm really trying to say as well is that the MDS coordinator has a very visible role in the daily functions of the long-term care facility. The growth of the industry is in place. I believe I've heard recently there's over 200 long-term care facilities in the Dallas-Fort Worth area. And I guess everyone has heard that, the baby boomers and more people are living longer, and so the need for long-term care is definitely in place. But as well as that, the CMS mandates are becoming very strict, are becoming visible to everybody. We have an annual survey. We also have a survey from the Office of Inspector General that comes in once a year and looks at all the assessments, and based on information that they derive from that survey, they can take money back from us. So that's another illustration of how much we need to be correct and accurate on our MDS data. We also have this year, actually it started in 2015, there's going to be a survey that's directly mandated to the MDS process in the facility. They're looking at the MDSs, they're surveying the information that we get, they're surveying the outcomes that we have, and we can get a tag from the Centers for Medicaid based on that survey. They're also looking at ratios between nurses and patients. They want to know, not only nurses, but they're talking about dietitian, they're talking about dietary managers. They're talking about all those things that are a function of MDS data. So we are going to be surveyed on that as well. And we're also having a survey that's already in place, and it's a dementia survey. And we would get real tags for this. If anybody out there knows what a Medicaid tag is, they can vary in severity. So we are going to be surveyed on how we deliver care to our dementia patients. So that's another, I guess it's another process that lets the government know that we are treating our older population well, that we are treating them like they're anybody's mother, grandmother, and whatever. They want to make sure that these people are taken care of. And I think as nurses, we all want that. I mean, I remember as a little girl, I wanted to be a nurse. So, and it's to help others, to make sure that we can help them and make a difference. So I think that is very important to me as well. Okay, MDS coordination position. In my facility, there are 2 MDS coordinators. One of them does what we call Medicare assessments, and the other one does Medicaid assessments. And they vary in a large way because reimbursement for Medicare patients is much higher than reimbursement for a Medicaid patient. For instance, in my facility, I'm the Medicare Coordinator, and we have a rate over $500 a day for every Medicare patient in the facility. The Medicaid rate for our residents in the facility is $144. So you can see the difference in reimbursement. So it becomes quite a challenge to make not only the budget. See, over $500 a day for Medicare in my facility is about $60 or $70 over the budget, over what they have set for that facility to bring in. So a Medicare patient generally, they have 100 days benefit for skilled services. That means rehab, that means IVs, that means a lot of skill set that requires that they be rehabilitated. So that's about 100 days. It doesn't always last 100 days because sometimes they get really improved, so we have to take them off Medicare. So Medicaid, in a lot of ways, is much more challenging because the rates are much lower, and we have to make sure that we capture every single pain, every single fall, every single injection, antibiotics, infections that are grown there, wounds that are grown in the facility. We have to have all that information that actually goes into the MDS. So when it's a Medicaid patient, it becomes harder because a lot of these residents that are on Medicaid are really there for custodial in the broad sense, and only becomes different if, for instance, that patient becomes ill or they fall. We have to send them to the hospital. Then if they have the benefit, on return, they will be skilled for a period of time. So it just becomes a little bit more difficult in the Medicaid sense to make sure you pull together everything that's available to put on the MDS. Now, I've been in this MDS, and I call it a discipline. I really believe that MDS coordinators are a special discipline in this long-term care industry. And just to say a little bit about that, most nurses in the facility that are on the floor, they're on the floor, they're ADONs or they're DONs, sometimes they don't really understand what an MDS coordinator does. Okay, and it's a matter of educating the staff to the importance of what you do in this process. So one of my goals is to offer training not only to become MDS coordinators, but also to the staff, so they have an appreciation and understanding of how the process really works. So some facilities have one, some facilities have two. I know of one facility that has about 5 MDS coordinators. Now everybody's interested in the salary part of this, and it's very interesting. When I first started doing MDSs, I made a certain salary. 8, almost 9 years later, I make about 75% more than I did when I first started. So the opportunities are there, not only for increase in salary, but also a recognition of the position of an MDS coordinator. I think the stronger you are as a coordinator and the more knowledge base you have about clinical data and their outcomes and all the things that go into nursing, then you become a much better nurse as well. So I really am interested, and I'm going to be teaching my students that this is really a skill set. This is a profession. This is something that we can take and we can right now we're still in a position where we can make it even more specialized than it has been in the past. And I really believe it is a specialization within a long-term care situation. So the salary can be really interesting. Most of the places that I have worked, it has been an hourly position. So that's something to think about. Sometimes they are salaried, but in my experience, they have been hourly positions. So to date, as far as certifications and requirements are concerned, basically to be an MDS coordinator, you have to have a nursing license. You have to be an LVN, LPN, RN. You have to have at least that certification in order to be certified through the state to code MDS. MDS is for the state, so you have to be a nurse. You have to be RUG certified, which is a RUG utilization group. That's just a list of different RUGs or different outcomes that mean different dollar amounts for reimbursement. So you have to be certified in that as well. Another certification that's real important in the industry is our ANAC, American Association of Nursing Assessment Coordinators. So that is it's not a requirement, but it's recognized in the industry as a very good certification to have. So basically, those are the only certifications that are more or less required in the industry. And I personally think that we need more education, more understanding of the process, more opportunities to become trained, to take advantage of everything that's in the industry, long-term care, stay abreast of all the changes in MDS coordinating come in October of every year. And what that means is CMS sets another standard for reimbursement, a dollar amount for reimbursement for this region. So they set it every October, and then the facility at that point sets their requirements, their budget. Usually they set it a little above what CMS sets. So that, that's how it usually factors out. CMS says this is the reimbursement rate in your area for this drug, for this, outcome. But the corporations, in order to make a profit, raise that requirement maybe $1 or $2, somewhere in there, so that they feel they're making some money. But so the certification requirements, we have a few, but really not very many. So my goal is to educate our students to the full understanding of what MDS process is, the history of it, the special skill set, the understanding of rules and regulations, and agencies that we have to deal with on a daily basis. It's CMS, it's Medicare, it's the OIG, we have to deal with all these rules and regulations every single day. So I want to really train everybody the full scope of the whole process so that we can have very professional, very well-trained nurses with a terrific skill set to deliver clinical outcomes. So that is my goal, and I hope that this has been helpful. I will be available to hang on. Our training versus others. Basically, as I have just said, there are no really certifications for this. There's no formulated training program for training MDS coordinators. So we have done a lot of research. Our marketing team has gotten so much information about what's available out there for MDS training, and really there's not a whole lot. I think we found there was maybe a couple of online schools, I think, that offer MDS training and or certification. ANAC is different in a way because their certification doesn't teach you basic things like I've just talked about. What is an MDS? What's the history? What does it look like? What purposes? What's the purpose of an MDS? That type of thing. So learning basic information about the MDS process, I think, is very vital because it equals reimbursement and it affects the clinical outcomes for our patients. In other words, the training, in my view, will provide better care for our residents and their families as well.
Okay, Rosemary, thank you. A lot of information in a quick, in a small span of time. So at this time, I'm going to start off with some questions for Rosemary, but we're waiting for you guys to go ahead. If you want to begin to go ahead and ask your questions. As I said, any question, whatever question you have on MDS, please feel free to ask while we have our expert here to answer those. Now, Rosemary, you mentioned that when you started as an MDS coordinator, your salary has increased by 75%. Now, you're talking about a span of 8 to 9 years. Why do you think that the demand for a well-trained MDS coordinator has gotten to a point where you are making, or an MDS coordinator can make a lot of money as a result of good training and a good coordinator?
I think partially the answer is that corporations and nursing home administrators recognize the value of having a very qualified and trained MDS coordinator in the facility. They are recognizing that there's a value to having a very well-trained MDS coordinator in the facility, and they, in my experience with the administrators that I work with, they have always valued the MDS coordinator's knowledge base, the knowledge related to clinical issues, the knowledge related to team playing, work depending on each other and not being isolated, as many of us sometimes do. I've done it too in the past, but they want somebody that can be part of a team that all have the same goals. My team includes rehab, the business office manager, it includes our social services person, and it includes the MDS coordinator. And many times it includes the administrator as well. So I have a fact here. MDS coordinators, as of September 2014, according to payscale.com, the range for MDS coordinators was 42,414 to 76,955. Now, obviously, it's not broken down by LVNs or RNs, and so it's just a span overall of that. So you can see that, I mean, that's a very good range, 42,000 to 76,000. And I really believe that that's the better trained that you are, the more you can expect to be paid for that position. But the administrators, the VPOs, everybody in that structured long-term care, they know exactly what they need. They know exactly, who they need in place to do that. So you have to be a team player. You have to be personable. You have to be able to take charge. You have to be able to lead. You have to be able to coordinate your information as well as the people that you work with.
Okay, now you've given us an idea of the range of the possibility of salary. Now, why now? I mean, why is it so important that we have a well-trained MDS coordinator? I mean, versus 8 years ago, what has transpired 8 years ago to now? What is it that you see? What is the big difference you see what an MDS coordinator was then and what an MDS coordinator is now?
Okay, well, let me just illustrate something to you. When I first became a nurse many years ago, as you've heard, the process of collecting data for reporting to the state was basically the DON assigned a nurse in the facility to collect this data to send it to the state, to CMS or to Medicare. So it was assigned to a nurse that was already on staff. So basically that nurse just collected the data, and there was not a whole lot of team effort. It was that nurse's sole responsibility to collect that data and to send it to CMS. So that has changed. That definitely has changed, because now, as the years have gone by, it has become more important because of demands from the industry itself. Is CMS or Medicare, they have demanded better care for the residents, better interventions, better response to needs than ever before. So I think that has made the demand and the reimbursement I believe that the more, the more you receive training and the more your skill set becomes refined and broadened, because it can become refined, but it's a very broad skill set. So I think the fact that I have been in the industry this long has raised my skill set tremendously. I have a very different vision of what nursing is all about that I had before I started doing MDS. I have learned the big difference between just being a nurse and really understanding the processes that go along with it, and what are the outcomes of what I do? What are the outcomes of what I document on the nurse's notes? So I've become much more knowledgeable. I've been able to be recruited more than once, and it's because of I have a very good history for reimbursement rates and for reimbursement in terms of the skill set. And so I'm thinking that it's also the industry changing, the demand for more long-term care facilities, and the demand for better trained employees within that setting.
Okay, great. Now, a question. It seems like an MDS coordinator today, it seems like it's a very high level skill set. It's becoming that more and more, it seems like, in the industry. Do you ever see an MDS coordinator having, or a state coming in saying, I think because we're at this point, at this juncture in the industry regarding the MDS coordinator, do you ever see the possibility of maybe becoming a mandatory certification because of the skill level?
I personally think it's headed that way. I think because there's no formal training for this process, that it may lead to that. I know that a lot of industries are much more interested in MDS coordinators, and more people are oh, you're an MDS coordinator. They really know what an MDS coordinator is. Now, I may not know the broadness or how it really looks, but they know the importance of what you do in that facility. So I think more people are becoming aware of that. The knowledge base is much better than it used to be. I work with social workers. I work with outside entities. I work with dietitians out in the community, with home health, with hospice, with respite. We work with all these agencies, and when they come in the facility, one of the first things they want is an MDS. They want to know what the level of that patient is. They want to know what their quote-unquote rug is, how much reimbursement they're getting. For instance, a hospice agency, when they come in to do an evaluation for a patient, they want to know what that rug is on that MDS. So the first thing they want is an MDS to make that determination. So we are more and more becoming a vital part of that function within the facility. And it's sort of like, okay, there's a go-to person in the facility, and the one person that knows about the patient is the MDS coordinator. So we get a lot of referrals from different people to give them information that we have at our fingertips.
I have a question coming in. How will becoming certified through your program help improve employment opportunities? I think we kind of answered that a little bit, but what is specific about our training, Rosemary, that will make a difference?
Well, number one, there's not a whole lot out there, number one, but I believe that you would get a broader training, a broader picture of what this whole process is about. It's not just about collecting data and putting it down and coding it in the MDS and sending it to CMS. It's about your nursing skills. It's about your managerial skills. It's about your entrepreneurial skills. It's about all that. And I think our course offers all that. We give you information on what's in the community, what you can expect from the community, And basically, I think that we offer a more generalized course, a more comprehensive course to teach you everything that we know about MDS process. And I don't believe that there's any company out there that's doing it. I know that there's one company that I'm aware of that teaches you how to fill up an MDS. But do they teach you the finesse? Do they teach you the critical thinking? Do they teach you clinical outcomes? Do they teach you how to do a care plan? All that, and we offer that in our course.
I have another question coming in. Did you say that MDS replaced tiles in 2010?
That's a mistake. It's 2008. Thank you for that correction.
Okay, another question. I'm already a nurse and want to become a MDS coordinator. Let's see, how long do you think it would take after going to the training?
I believe that you could start fairly quickly after the training. Now, I also believe and would recommend that you secure a job where there's more one than MDS coordinator, because that gives you the ability to have your knowledge base, but also to practice it and to have some mentoring done within that department. So I would recommend that. Yes, I really believe that you would be able to be an MDS coordinator with the training that we give, and a lot of it depends on how you present yourself to any facility, how your resume looks, what your training is, how long you've been a nurse, that type of thing. So I think you could secure a job with the training that we have, because let me tell you, right now there is no training. Basically, I was trained on site in 2008. I was trained on site, and again, it was sort of a situation, well, we don't have anybody else to do it. Do you want to do it? So I said yes. So there's really not anything out there that you can take to any job that you have, unless you've been working as an MDS coordinator, that really gives you value in your resume to say that you could do that. But I think with a training that you'll be able to answer any questions that an interviewer would give you.
Good. Another question. You mentioned that there are many factors that go into calculating Medicaid reimbursement rate. One factor you mentioned was pain. Can you discuss how a resident's pain level is calculated into the payment?
Okay. The way it works is the MDS coordinator does an assessment for pain that includes a 5-day look-back period. That's an MDS coordinator. Okay. A nurse on the floor does, or the charge nurse on the floor is going to evaluate pain every single day. So if my interview doesn't match hers, which in many cases it doesn't, then that patient will not get pain medication. So on the pain medication, there's a section in there. Is this patient interviewable? Has this patient had any pain? Does this pain keep the patient from doing rehab, from doing her daily functions? How high does the pain rate on a scale of 0 to 10? So we ask these questions to the patients. So if we do that, and then in another section, did this patient receive any pain interventions? Then, we're not delivering that. But if we deliver that pain medication to the patient because they have complained of pain, then we are reimbursed for that. We are also the state is very, very keen on making sure that our patients are not in pain. So pain is a very high, the acuity on that is very high. We have to ask that question every day, and that pain has to be addressed. If it's not addressed, another factor that comes in is on the quality measures. For instance, the long-term care facilities have a star rating from a 1 to a 5. Part of that rating has to do with quality indicators that affect that patient on a daily basis. And one of those factors is pain. So there's a lot of questions related to pain on the assessment, and a real focus is on that. So quality measures is a big effort as far as the quality, the rating for the facility, because we do pain, we do Foley catheters, wounds, G-tubes, all those things that we capture on that patient has an outcome as far as reimbursement.
Okay, very good. Okay, well, we're running out of time, folks, very, very fast here. So we're going to go ahead and move on. If there are any other questions that you might have, certainly you can go to our website and send those questions through there. And Rosemary will be more than happy to go ahead and answer any questions you might have. Now, what we're going to do at this point, we're going to go ahead and wrap things up. We're going to offer a training promotion. For those of you that are participating in our webinar this afternoon, we are going to offer a special promotion. We have a class that's coming up August 22nd, 23rd, and 29th, and 30th. It's a 32-hour course, and as you can imagine, there's a lot of information that will be shared and taught, and so it's a very thorough process that Rosemary and her team goes through in order to communicate and to prepare you for the outcomes that the industry is looking for and that you're looking for, obviously. And so those are all Saturdays and Sundays to accommodate schedules. A lot of our folks are working during the week, so the schedules work out very, very well as far as the weekend schedule. So the code that you'll need is WEB50. Now, what you'll do is you'll go to www.mdsltctraining.com, and you'll go to our training tab, and there's a registration tab right there. You click on that, and that'll take you to our registration. And if you enter WEB50, it'll automatically give you the 50% discount on that. Now, room is limited, so we want to make sure that you guys if you're interested in having the training, go ahead and go on there now and fill out the application. Let's see here, and let me just also mention that we are going to have another webinar that will be scheduled on the 1st of September. Now, this one's going to be an interesting one because we have a lot of feedback in regards to reimbursement, on the reimbursement rates. Any facility can turn in an MDS analysis and get paid for it. One of the problems that we're finding is that a lot of that money is being taken back, and it's clearly a result of documentation. We are real big on documentation. Rosemary, as I said, has a proven record of documentation and how to gather that information and how to come out with a good MDS analysis. So we'll be sending that out to you guys the 1st of September, and we'll be sharing that part of it. And the name of it is going to be, are you meeting or exceeding reimbursement rates? If not, why not? And again, second to that, the caveat to that is that if you are, then okay, how much money is being taken back as a result because of documentation? So we look forward to that. So it looks like we are going to wrap this up. We want to thank everybody that submitted questions and that participated in this webinar. We're very excited about our company making a difference in patient care and reimbursement. It's time, folks. It is time to make a difference, and we believe that we're going to be the leader in that here in the state of, and not only in DFW, but in the state of Texas. And we're excited about the possibilities. Again, if you have any information, feel free to give us a call. The number is there on the screen, 855-435-4925. And visit our website, MDSLTCtraining.com. And again, we're going to post this webinar onto our website, so it'll be there to refer back to. But again, we welcome all questions. If you have anything that you need answered, feel free to send Rosemary a question and she will get back with you, with an answer. And you guys have a great day and look forward to seeing you at our next webinar, the 1st of September. You guys have a great day.
Thank you so much.